Good afternoon, everyone. iTech welcomes all the participants for today's National Distance Learning Seminar Series. Today's topic is Frequently Asked Questions or Common Errors in MPR, and speaker is Mr. Archit Sinha. Mr. Archit Sinha is an associate consultant at NACO, and he specializes in public health management with more than 5 years of experience under different capacities in public health settings. He has delivered under different portfolios at NACO and is currently the nodal officer for monitoring and evaluation of care support and treatment services delivered across the country. We welcome you, Archit, for today's NDLS session. I would request you.
Thank you, Divya. Hi everyone, good afternoon. As we all know that today's session is on frequently asked questions and common errors in MPR, which has been observed that are persistent in reporting by the ART centers. So we will try to get answers to all those questions and rectify the common errors which are made by the ART centers while reporting their monthly report. I will try to answer your doubts during the session also, and if not possible, we'll take up in the last. So before we start towards our session today, we should need to ask 3 questions to ourselves, that is why, what and how. So if we talk about why, we need to ask ourselves why are we working, or why are we chasing the targets, what are we doing for. Second questions we need to ask ourselves is what are we doing. Are we doing the right thing to take up those visions to get all those targets. And thirdly, we need to know how we are doing. The what we are doing is how much correct it is. So we need to ask these 3 questions, and we will try to find out the answers in our slides during the session today. If we go towards the first slide and find out the answer for the why, so as we all know that globally the target for India has been set to end HIV/AIDS as an epidemic threat by 2030. The more near target which has been set by the set for the ART center is set for the ART services and the HIV/AIDS program is for achieving treatment targets of 90-90-90 by 2020, reduce new infections by 75% to the baseline of 2010, eliminate HIV related stigma and discrimination, eliminate mother to child transmission of HIV. If we go towards the target which is more nearer, or we can say is the target for the year which we are in, 2017, so that will be reduce new infections by 50% to the baseline of 2007, provide comprehensive care and support to all persons living with HIV/AIDS and treatment services, eliminate congenital syphilis. So this is one part of the why which we are working for. Now emphasizing more on the 90-90 targets by 2020, which has been told and which is being alarmed everywhere. So what it is, what exactly 90-90-90 targets are. So 90-90 targets, if we see, so there are 3 90s. First 90 talks about the diagnosed. That means the diagnosis of the estimated PLHIVs. That will be 90% of the PLHIVs should know their status. So through diagnosis we will fill in the first 90. Second 90 talks about those who have been diagnosed or know their status should be, out of that 90% should be on treatment. So that is our second 90. And the third 90 is that the 90% of the people who are on treatment should be virally suppressed. So out of those on treatment, 90% should be virally suppressed. So these are the 90-90-90 targets which we are thriving for, and we should know that these are the answers to our why. Now what are we doing? As we all know that there are many people working in different capacities at ART centers contribute towards the why. But I will be talking about one component today, that is monitoring and evaluation, what as an answer to the what, and we will see how we can work on it, what are the mistakes we are doing. So what is M&E? M&E is a process that helps improve performance and achieve results. Its goal is to improve current and future management of outputs, outcomes and impact through systemic collection, compilation and dissemination of the data. We need to know that our whole M&E systems depend upon 4 pillars. What are those 4 pillars are? First is completeness, second is correctness, third is consistency, fourth is timeliness, and finally all these 4 supports to build up the palace of M&E. So one by one, if we see what do we mean in terms of completeness. So all those data which is filled in the format used by the ART centers need to be complete. That means the format which is being provided for any information to the ART centers need to be completely filled and nothing should be left. Secondly, correctness. The data which is completely filled should also be very correct. And third, that is consistency. The completeness and correctness should be maintained consistently. So these are the 3 pillars. If we talk about the timeliness, so I will say that this is the base for the palace of the M&E. That means if we comply to completeness, correctness and consistency, it is very needful to maintain the timeliness. If we do all these things and our reports are not submitted on time, that is of no use. So timeliness is the most important thing. So with completeness, correctness, consistency and timeliness, we can improve our M&E system. Next slides will help us to find out how we can improve our M&E systems. And in direction of the same, I will first discuss some of the terminologies with their definitions which will be used during the sessions today. First is financial year. Financial year is a year that starts from April of the current year and ends by the March of the next year. That means if we talk about 2017-18 financial year, so it started on 1st April 2017 and will end on 31st March 2018. Reporting month or during the month. What do we mean by reporting month or during the month? These are the terms which are used in our formats also. So reporting month is for the month of which we are preparing the report, or we can say the report which is being prepared for the month which has been successfully completed. Cohort, a group of people with a shared characteristics. Now these characteristics can be anything like HIV status, all those in terms of if we say HIV status, all those being registered at the ART center, or the registration period. For an example, if all those people who have been registered during the month of June forms an cohort for the month of June in terms of the registered patients. What is cumulative? This is one term which is very much used in our formats and also confusing. So cumulative is increase by successive addition or accumulation over the time. We will also see further that there are 2 types of cumulative in our formats which are normally confused, but we will discuss it further. HIV TB line list. This is the line list in which those patients who have been are entered, who have been referred for TB confirmation test by the ART centers. What is HIV TB register? HIV TB register is an register in which all those patients who have been confirmed by the TB test and are registered to the ART centers need to be entered in this register. Treatment is stopped on medical grounds if an MO or the SMO of the ART center stops the treatment for the patient. It will be called as stopped treatment status of the patient. Opted out, not willing to continue availing services from the ART center. This willingness is of the patient. is termed as opted out. Miss, the patients who does not appear in their scheduled visit to the ART center are categorized as miss patients, and this is also we need to know this for the certain limited time period. LFU, as we all know, those consistent miss patients are known as LFU patients after some time. So LFU means lost to follow up patients, and these are those patients who does not appear for consecutive 3 months duration from their last scheduled visit to the center. And lastly, the adherence. Adherence means it refers to the patients, patients availing the ART medicines or eating the ARTC medicines. Now we will see that what are the mistakes made by the ART centers, or common mistakes which are not being observed and are repetitively done during the months before reporting. So first of all, it is recommended that always download a new copy of MPR format before preparing of a monthly report, and this can be downloaded from the NACO official website, going through the CST division link, and from there you can see the care, support and treatment tools is the link from where you can download. In-depth detailed video of the MPR usage has also been uploaded on the NACO website recently. So you can also see all these videos which will help you in understanding your MPR nicely. The common errors which we are seeing when we get the reports from the ART centers are that there are some basic information which is lacking. The basic information which is scattered at the first page of the MPR, like the unique code of the ART number, name of the ART center, and many other details like name of the nodal officer of ART center, contact details of the nodal officer of the ART centers. These kind of information. We have been trying to automate most of the things which need not to be filled again and again, which remains consistently same. So the ART code has been made to standardize this, and what you can do is that very first time after downloading the MPR, you need to copy paste your ART code in the column of unique ID code, which will help you in filling some of the basic information which is not changing every month. So this is need to be done. Secondly, what has been observed that the basic information regarding the manpower, like all the vacancies which is vacant, which is not vacant, or the LAC data, that which LAC is linked to the ART center and which is not completely updated. Mostly in LAC, if ART center has been linked to 5 LACs, ART center, what does it has been observed that only 3 LACs data is scattered and 2 are left. So that is not the right thing. Moving towards the indicator, if we talk about the 2.1, it needs to be the 2.5 of the previous month. We need to understand it that the 2.1 is the opening account of the ART center in terms of the registered patients, and 2.5 is the closing account. So 2.5, that is the closing account of the previous month, should be equal to the 2.1 of the current month which is being reported. Secondly, we will discuss about the 2.11a and 2.12 in depth. As we all know that this part of the MPR contributes toward retention cascade and also been modified by adding some more indicators. So what are the common mistakes which have been observed in the reports submitted? Like if for an example, if we take that the month of for the month of June the report is being prepared, so 2.11a, that is total number of patients registered in HIV care during the current financial year, April to reporting month, should be total of the 2.2 of the month. That means if we are preparing for the if we are preparing report for the month of June, so it should be total of April, May and June. That means 2.2 of April plus 2.2 of May and 2.2 of June. But certain variations are always observed. Either the 2.11a is higher than the total of the 2.2s or it is lower. So it should not be like that. Secondly, a common question which has been multiple times observed, that whether transfer in should be included in 2.11a or not. So no transfer in should not be included in 2.11a. 2.11a should not have any transfer ins. Third, 2.11c should be equal to 2.11a as per the new guidelines. As we all know that test and treat guidelines have been released. So 2.11a, which is registered, all the patients are eligible for ART. Last, 2.12 in the June should be equal to 2.2 of the April. If we talk about the 2.12 indicator, it says total number of patients found eligible for ART month prior to reporting month, prior to 2 months prior to reporting month. That means that if we are preparing for the month of June, the June report is being prepared, so all those patients who were eligible will be in the month of April will be indicated here. Now if we say that 2.2 is the registered, so again going back to the point of new guideline that all registered are eligible, so it remains the same. So 2.2 should be of April will be equal to the 2.12 in June report. Now going towards the retention cascade. This retention cascade has now been added to the analysis sheet of all the MPRs being sent by the ART centers to their respective secs. This need to be really observed very closely because it is the real monitoring indicator of the performance of the ART center. And where does it come from? From the MPR. It can be seen here that number of patients registered in the financial comes from 2.11a, percent of PLHIV undergone baseline CD4 comes from 2.11b, percentage PLHIV found eligible for ART is 2.11c, PLHIV initiated on ART and PLHIV retained on ART. Initiated on ART and retained on ART, it should be mentioned that these are the two things which are exactly contributing towards our second 90 and third 90. The retention will contribute towards the viral load suppression and initiation will contribute towards the second 90 of the 90-90-90 target for 2020. Now similarly we need to understand in terms of 3.1 and 3.5. Again, the 3.1 is number of PLHIV ever started on ART at the beginning of this month, and 3.5 is number of PLHIV ever started on ART at the end of this month. So again 3.5 here similarly similar to 2.5 is the closing account and 3.1 is the opening account. Taking an example of preparing June report, if we are preparing the report of June, so the 3.1 of June report should be equal to 3.5 and no variation should be seen, as the arrow also marks the same. Now we need to discuss about some errors which is reported in deaths, stopped and LAC columns. Cumulative number of deaths of PLHIV at an ART center cannot decrease. It is seen that ART center decrease the number of deaths happening at their ART center once reported after reporting, which depicts a wrong picture at the national level. So no, the death which has been reported cannot be decreased. Similarly, in the section of LAC, as I earlier told, the required number of LAC column linked to ART center at first sheet category basic should be added. If there the information is not added, it will not depict in 3.11 and that will project a wrong picture, or you will have to enter all the data in only one LAC. So you need to add the separate column for all the LACs on the first sheet. In the list of LFUs, the indicator 3A1 has again has been new in the MPR. So this talks about the number of patients in the list shared with the Vihan in the month prior to reporting month. Now we need to understand, again taking the example of if we are preparing the report for the month of June, the indicator 3.A.1 means, for example, the number in the month of June will be equal to the number which has been to the list which was shared during the month of May. That means 1 month prior. Similarly, out of 3.A.1 number of patients successfully contacted by Vihan, and earlier it was that initiated on ART 3.A.3, now it is linked back to ART center. This can be either the follow-up of the CD4 or any ART initiation, or the patient was already on ART and was went under LFU. So this caters everything, as that's why it is said number of patients linked back to the ART center. The PPT-CT data, what common errors has been observed, that this data is for the financial year and not for the reporting cumulative data. So the financial year data has to be reported, and the 3 categories which are newly registered women, already registered in pre-ART, already registered on ART has definition. Newly registered women would be those women who have been for the very first time introduced to the system of ART system. That means for the very first time that woman has been detected, and for the very first time she has been registered at the ART center. Already registered in pre-ART women means all those women who were registered in pre-ART care at ART center and has now become pregnant will be included in this column. Similarly, already registered on ART, all those women who were taking ART from the ART centers and were already registered will be included in this column. EID data, again the centers are reporting it cumulative data, but it has to be the financial data. The error which has been seen, that the ART centers are, some ART centers are reporting it as in cumulative data, but it has to be the financial data, and only those children confirmed by DNA PCR below the age of 18 months has to be reported in this indicator, in these columns, and not those children which have been referred for the test, only those who have been confirmed by the DNA PCR and are below 18 months. Coming towards the intensified case finding and diagnosis, HIV TB data, it contains both the sections. The first is that it also has the reporting month data and the cumulative data. Reporting month data has to be seen that cumulative data is not entered into these columns. All those patients all those patients attending ART center during the month, either be pre-ART or ART, has to be entered here. All those patients attending ART center need to be screened for the 4S screening, and all those found 4S positive with even 1 4S positive by the symptom of the 4 positive, so they need to be sent for the preventive TB diagnosis. This is the 4.C.6 further bifurcates for the in pre-ART care at the time of TB diagnosis. It can be possible that the patient was not on ART at the time of diagnosis and now has been put on ART. So this is as per the TB diagnosis, as at the time of TB diagnosis. Again, this is the HIV TB part, and this is the financial year part. This all data is the financial year part and not the cumulative part. So financial year data has to be entered. Similarly, the IPT data, the exact correct IPT data needs to be entered. Certain questions were collected at the national level, that how to calculate adherence. So adherence formula is number of pills consumed by the PLHIV, which information is gathered when the PLHIV visits the ART center on the follow-up, divided by number of pills he should have been taken, multiplied by 100. So the number of pills which was given he was supposed to take and how much he has consumed. So the consumed divided by how much he should have been taken into 100 will be the adherence. The calculation in the adherence need to be entered in 3 categories. As we all know, the standard acceptable is above 95% of adherence. That is very much acceptable. Average and poor, separately all those patients falling in these 3 category will be entered, and 5.1, which is the total number for which adherence has been calculated, is automated and will be calculated automatically. Coming towards this section number 6, which talks about the risk factor. There were many questions on the risk factor which was sent to the NACO. First of all, we need to know that the real status or the right information, the complete information about the risk factor we need to know. So the disclosure of risk factor is important. If right information is not attained in the first visit, then counselor should explore the fact if required, but not compulsively, and the same must be recorded in the records. The section contains both cumulative and financial data if we talk about the risk factor reporting. The first section is then cumulative. The first section is from 6.1 to 6.7, that is a cumulative data, and from 6.8 to 6.10 is an financial year data. It is also been seen that there are many patients which fall under 2 categories of risk factor. So those individual patients should be counted twice for the different categories. Section 6.A, regime used during the reporting month. So this is the reporting for the month for which the report is being prepared, and all those patients which are mentioned, either adult or pediatric, resume wise should totally be equal to 3.10, that is alive and on ART. So this should be equal to 3.10, the patient distribution on resume. Now opportunistic infections, if we see, and comorbidities. So there are 2 parts, 7.1 and 7.2. Now first we will understand about 7.2 and then we will go to 7.1. 7.2 talks about the OI happening to the PLHIV. That means a patient can have only one OI, that is either of the OIs listed in the report, or it can have one or multiple OIs. So first, if we are having a patient which has one OI, that means taking the example of Ram, he is an adult, he is on ART and now has got an OI pulmonary TB. So the Ram has been counted as one in pulmonary TB. Similarly, there is Kusum, she is adult, on ART, has got OI pulmonary TB and diarrhea both. So one has been counted in diarrhea and one has been counted in tuberculosis. So here total OI will be 2 and total OI of pulmonary is 2, diarrhea is 1. And now if we go to indicator 7.1 which says PLHIV having 1 or more OI, so this will be only 2. That means Ram and Kusum individually. What is the error which is seen? That the centers report 2 plus 1, 3 in this column 7.1. It has not to be done, it has to be 2 and the episode has to be recorded here. This section talks about side effect. All possible side effects observed has been included in the list and the more detailed information can be provided by the SMO and the MO of the ART centers. Section 8, that is very important, drug stock of the ART centers. Drug stock of the ART center at the beginning of the month should always be equal to the drug stock of the ART center at the end of the previous month. That means there should not be any variation in the stock closing and the opening between the 2 months. If the previous month is closing the stock at 100 tablets, the opening should also be on the 100 tablets. But the discrepancy is observed very commonly. So this should not be done. Whereas the consumption reported in 4 weekly reports sent by the ART centers to the SACs should be equal to the consumption shown in the monthly stock report. So as we all know that all those 4 weekly reports only contributes towards our monthly report. So consumption reported in the 4 weekly report should be equal to the 1 monthly report. 4 weekly report to 1 monthly report. ART monitoring of the CD4, the data captured is the monthly data. That means for the month of which the report is being prepared. In this, the CD4 conducted at the ART centers are calculated and reported for the pre-ART and ART patients. The viral load section need to be filled by only those ART center conducting viral load for their patients. Section 10 talks about the second line ART. Second line ART, this is the cumulative data, second line ART cumulative data from 10.1 to 10.11. In this we need to know that 10.10 has to be only entered by the COEs which are providing the third line ART. This is the cumulative data. Again, the 10.5 of this month will be, if we are closing the data 10.5 of some month, it should be equal to the 10.1 of the other month starting. That means if we are preparing for the report of June, so 10.1 of June will be equal to the 10.5 of the May. The second line data, it has been observed that is not filled by all the ART center. It needs to be filled by all the ART centers providing the second line ART. As I said that this is the cumulative data and not an financial year data or the reporting month data. The second section of the section 10 is regarding the financial year data 10.A.1 to 10.A.8. This is the financial year data, and similarly all the information correctly has to be entered in these sections. Now we will go towards the some frequently asked questions which were given to NACO to be addressed. First question is, Ram was a CLHIV and included in MPR as pediatric when registered. Now he has grown to adult, so where to include? So answer to this question would be, his status should be considered as on registration. Patient is referred for TB detection test in last week of the month and report is received in first week of the next month. How to report? The number of patients which fall in this category are really less, as it would be the last week of the month which are being sent, and the strategy of speeding up of the report should be adopted so that the correct reporting could be done. What will be the date of eligibility for new patients and for old patient already in pre-ART care? In new patients, it will be the date of registration, and in already registered patients, the date of visit to the ART center, now which they are visiting, will be the date of eligibility. Is it that all patients who are 4S positive are subject to presumptive TB diagnosis? Yes, I already said that all patients who are found even any one of the 4S positive symptoms should be sent for presumptive diagnosis. What should be given in indicator 4.C.1 if a patient visit multiple times in month to ART center? Total number of footfalls of PLHIV should be reported in the indicator. Whether 3.A1 includes all patients, that is on ART, LFU, pre-ART, LFU, miss eligibility but not started on ART, CD4 due patients? Yes, all patients to be included. Whether 3.A3 includes whether only restarted on ART patients? No, it will include all the patients linked back to ART centers. Despite TG being a gender, why is it mentioned as a risk factor? Yes, TG is mentioned in the risk factor because it is a part of high risk group. Some questions like, if a patient falls in MSM and TG, where to include in MPR? It has to be included in TG. If patient is FSW and serodiscordant couple, where to include in MPR? So it will be included in FSW. If a patient is MSM and serodiscordant couple, where to include in MPR? So it will be included in MSM. Again, like, who will fill indicator 10.10, cumulative number of patients shifted to third line ART? So this indicator has to be only filled by the center of excellences, those who are providing the third line ART as of now. These are some commonly ignored errors which should be checked before submitting of the reports. Like this kind of, like, if you can see, this kind of columns should not be there before submitting of the report. If there is a column which is empty and need to be compulsory filled, it will turn red. So this should not be there. This kind of depiction should not be there in the MPR. So with this, I would like to end today's session by thanking Dr. R.S. Gupta, DDG CST NACO, Dr. B.B. Rewari, Dr. Manish Bamrotia, Dr. Sudhir from Gujarat SACS, all the RCs, Dr. Sukama and iTech India for their continuous guidance and support. And I also thank CST team at NACO, all SACS and all ART centers for their presence and support.
Thank you, Archit, for this informative session on MPR. Thanks to all the participants for patient listening. Any of the questions which are not answered or addressed during the session, we'll be sharing the same with the recorded link. All the participants are requested to kindly enter the e-poll which is going to display on the